Hello, my name is Glenn Kader. I'm a partner of Dr. Callaghan's and Dr. Wagaspack's at the NeuroMedical Center, and today I'm going to talk about depression and anxiety and Parkinson's disease. It's going to be more about depression, but let's just get into it. So, before we talk about depression, let's talk about the brain a little bit. How does the brain work? So the brain works using electrical impulses to relay information. And the electrical impulses rely on neurotransmitters, which is a chemical in your body. The problem in Parkinson's disease is that the actual neurons, which allow the conduction of the electrical impulse and also store and have a role in producing the neurotransmitters, are less. So it's a neurodegenerative condition where the neurons die away over time. When the motor symptoms are noticeable and available, that process has already been underway for many years, unless it's an induced process like the drug that was mentioned earlier in Dr. Camella's talk. So depression is, we'll go into the details of it and exactly where, but depression, it's not just a reaction to a life event or a series of events, it's a change in the chemicals in the brain. So if you have a neurodegenerative process, you're really susceptible to having depression or anxiety or other problems that arise organically in other people. So when you look at this slide, depression, it talks about different areas in the brain where you have those neurons and the neurotransmission. So the ventral tegmental area, that's really heavy in the dopaminergic system. The mesocortical limbic system, which is a great word. You put in enough O's in a word and put on endings and beginnings, you can have great words like this that it really just looks at the different structures in the brain. That has both serotonergic, which is serotonin, which is really prominent in depression, the lack of serotonin, dopamine, and noradrenergic, which is norepinephrine. Two other particular areas, the raphe nucleus and the locus coeruleus. Got that out pretty good. I'm excited. So that those are two different types of neurotransmitters that we use to help treat depression. So we talked about how the brain works a little bit. So when you think about the brain and depression and what we use to treat depression and to treat Parkinson's disease, we're in Louisiana. You know, if we were somewhere else, you might call it a neurochemical soup. We could call it a gumbo, and everybody's gumbo is a little bit different. Some are a little bit more spicy, so a little bit more dopamine. Some are a little bit more flavorful, so you have a little bit more serotonin, or whatever other neurotransmitter you want to talk about. It's a little bit different. So what we try to do as physicians and other practitioners who try to treat these problems in the brain, we just add a little bit of spices here, a little spices here, a little bit of neurotransmitter, try to bump it up, lower it down, depending on the particular problem. So I think it's very important to recognize that going in, or else you might not really appreciate what we're trying to do to your brain. And, you know, anytime obviously we're not there for the formation and the development of someone's brain, so we're there whenever there's a process going on that's abnormal. So we're trying to just add a little spice here, a little bit there, to try to change up the neuro composition of your brain to give an effect. So this is a picture of your brain, and it just talks about the different areas that we mentioned. The nucleus accumbens is 1, the ventral tegmental area is 2, and if you notice that it goes throughout the brain. It's not just in the deep brain that we were talking about earlier in the substantia nigra when a lot of the dopaminergic neurons are, but it goes to different areas. So that's just important to realize that although we talk about neurodegeneration primarily in a certain area of the brain with the movement symptoms of Parkinson's, those effects are located elsewhere. And that's where you get a lot of the non-motor symptoms of Parkinson's. You also have premotor symptoms. So before the symptoms of Parkinson's that are classically described by Dr. Parkinson's way back, before those happen, you already have a process ongoing for many years. And you have symptoms, although they may not be attributed to a neurodegenerative disease at that time, it's as a result of it. So people have constipation, they have changes in the way they smell, they could also have depression and or anxiety. Up to 30% of people, before they're even diagnosed with Parkinson's disease, have that. And that's a high number compared to the general population. Now in Parkinson's disease itself, as the neurodegeneration gets worse and people are symptomatic, that number rises. Between 36 to 50% was a number quoted. It's somewhere in there, 40%, 45%. Those are just different studies looking at different populations groups for it, but that's a pretty high number dealing with depressive symptoms. Now, major depressive disorder is different from dysthymic disorder. That is slightly different from another disorder that we'll talk about, but it's dealing with those problems. Neurotransmitter loss, we already mentioned that as the underlying problem. So it's a complex underactivation of the frontal and limbic cortex, which, we showed that picture. And it's also dealing with the new reality. So obviously with Parkinson's disease, you have limitations on your physical activity and well-being, and that's not easy to deal with. So it's a more complicated picture than someone in general life without a significant medical disorder being depressed. And I think that's important for everyone to recognize that, because, well, let's talk about depression first and then we'll get into that. So, major depressive disorder, it's the more significant form of depression. It's people in today's life and society, we'll watch a movie and say, gosh, I'm depressed. That's a sad movie. But we get over it. For major depressive disorder, so it makes us kind of trivialize the word depression. What we mean is having a clinical decrease in function. 5 of these symptoms of the 9 that are up there to fully classify as a major depressive disorder present for at minimum 2 weeks, oftentimes, much often longer. Everybody has to have a depressed mood and some form of these different symptoms. So I'll talk about these a little bit later, specific to Parkinson's disease, but they focus on the way you perceive reality, on the way you express yourself, and on the way that you move to some degree. Dysthymic disorder, it's a more prolonged form of depressive symptoms. You don't have to meet that rigorous criteria of major depressive disorder, but it doesn't mean that people aren't suffering from the symptoms of sadness and lack of motivation, etc. Minor depression, we're not going to go into that, but it's just a lesser syndrome. Adjustment disorder with depressive symptoms. So that's important because a lot of people who have Parkinson's disease, we talk about depression and they'll say, well, I have Parkinson's, I'm depressed. Yes, okay, but whenever someone has a major event in their life and it causes some prolonged feelings of sadness, you can't call that depression unless you meet those rigorous disorder symptoms that we mentioned earlier. So you have an adjustment disorder with depressed mood, and as time goes on, you either get better, or you have a major depressive episode, or you fall into a dysthymic state. But, people face things often in their life, just like many of the people here are dealing with this disease, Parkinson's disease. But as we mentioned, y'all have some extra disadvantages when it comes to depression because of the neurotransmitter changes that aren't just changes in the transmitters, but a change in the actual neurons that are there available. Comorbid features that go along with depressed mood: anxiety, substance abuse, psychosis, mania. And I'm being a little quick, so y'all are going to have to forgive me. So in Parkinson's disease specifically, less blame, less guilt, less sense of failure, less suicide, less self-destructive thoughts, which kind of makes sense in the totality of things, because Look, it's not your fault you have Parkinson's. You know, it's not your, and everybody recognizes that. You know, so I think it has some psychological consequences of that. So the thoughts that are there in the general population in major depression are a little bit less. You do have, unfortunately, more fatigue, more apathy, more loss of initiative, more comorbid features with anxiety and panic attacks, and more anhedonia. So that's just a lack of caring about oneself, appearance, etc. This slide is kind of blank, which is okay. The reason why I left it like that is to talk about general things that we could do even in a Parkinson's patient without adjusting medications. Labs, you want to make sure your thyroid is optimized. You want to make sure that you have enough B12 in your body, enough vitamin D, and those are things that we could check and make small adjustments if needed that could have big benefits. A sleep study. Parkinson's affects sleep. For those of you who were here last year, we had a cool video of someone who had REM behavior disorder and he's thrashing about and yelling. Well, that affects your sleep. You could have periodic leg movements. You could have sleep apnea. And if you're not getting the required sleep, it could certainly affect your mood. And those are things that can be addressed with either medication or medical equipment. Roadblocks to treatment. Is it generational? There is some thought that an older generation who's dealt with a lot in their life, they may have more of a pull oneself up from the bootstraps mentality and don't really want a lot of help in terms of medication. But I know firsthand from somebody that's close to me, he's just as stubborn and doesn't want treatment anyway. So I'm not really sold on that thought process. Points to consider about depression, which may really push someone into taking pharmacological treatment or other types of treatment. It could worsen the apparent cognitive function, and that's a problem in Parkinson's disease anyway. It could cause physical symptoms itself, pain, discomfort. Yeah, I'm sure, you know, if anybody watches TV, they'll see an ad for Lyrica, they'll see an ad for Cymbalta, different drugs that help with chronic pain syndromes, and depression has a big role in that. The depression itself can augment the impact of physical symptoms. So what does that mean to a Parkinson's patient? You have physical symptoms, you have Parkinson's. So if you experience that to a greater degree or it caused you more angst, well, that's something that can make your life worse. Those numbers under there, 40% in a 2-year period, well, that means that approximately 40% of the people who have depression can relapse within 2 years. And of those people, the risk of recurrence within 5 years is 75%. You could drastically reduce those numbers with appropriate medication and or therapy. All right, we could skip that. Just listen to your doctor. Don't just change things up. That's helpful. I had somebody the other day come in. Well, we stopped Cinemet. Just, you know, it ran out and just wanted to see what happened. And they didn't like it, but you could do that. But just especially with antidepressants, because it takes a while to build up and see effects, etc. So that's something that you need to be careful of. Types of treatment, pharmacotherapy, which we're talking about here today to some degree, psychotherapy, behavioral therapy in combination, some of the behavior aspects that were addressed earlier today. Exercise, it's very important to exercise as much as you can in depression, in people who are depressed, as well as the Parkinson's patients, as mentioned earlier. Psychotherapy, because Parkinson's is a medical condition that has a loss of neurons, along with other medical conditions that make depression more difficult to treat. It's often you get to the point where you need the help of a psychiatrist or psychologist. And the combination of both medical treatment in the form of medications and medical treatment in the form of talking about the issues has shown to be beneficial. Treatment will go fairly quickly on that. Remission is the goal of treatment. You don't want to just get partially better, you want to get all the way better. If you don't, it could linger and has a higher rate of recurrence. Most people start low to avoid side effects and then build it up fairly frequently. Initial response from most antidepressants are between 2 and 6 weeks. At week 8, that's 2 months of treatment. That's a pretty big point because most of the drugs work by that time. And if they work somewhat, you might need to add another drug to it. If it doesn't work enough, you might need to switch drugs, etc. You might need to look at another form of therapy added to it. It just depends on the specific case. Maintenance is needed once someone recovers from their depression. Should they stop taking the pills? Studies have shown no, because they have a much higher rate of relapse. This goes along with anxiety. Numbers that we'll see later if we get there is 53% rate of relapse for one patient population studied in anxiety that stopped their SSRI versus 9% within 6 months who didn't. That's a big figure, especially for something that is so destructive to one's life. All right, specifically for Parkinson's disease, azilect. It's a very common drug that is given in Parkinson's disease. They used to have all these warnings of should we take antidepressants with it. Obviously, we've established that depression or anxiety are common in a Parkinsonian process. So it's a key feature in treating someone with the disease. Now, if you're on this medication, there are some worries that you couldn't use antidepressants. That has not really proven to be true. You just really need to follow the FDA guidelines and stay within the amounts recommended for different medications. Serotonin syndrome is very rare. Hyperreflexia, rigidity, mental status changes, autonomic instability, such as sweating, high blood pressure, fever, tachycardia, all unpleasant things. So that's a risk with it, but as stated, it's very rare. SSRIs and motor exacerbation. It's a little bit worse with Paxil and Prozac, a little bit better with Zoloft, and this is just with the drugs in general. Obviously, in someone with Parkinson's disease, you got to think about those things. But if we look at these studies, which, by the way, I didn't list them out individually. I got them off up to date, so I didn't just make them up. They're there, and you could look at that if you want to. So one survey demonstrated that clinicians, such as myself, are worried about that. You know, almost a little bit more than a third of the people in my position have seen one instance or more of people getting worse on antidepressants. But 2 studies looking at that show that it's not very common. A retrospective case series, which means looking back at patient data, showed that only 5 in 58 patients had symptoms, and of those, you can kind of blame it on something else too. Not 100% maybe, but something else is going on. And in 3 prospectives, which means you start medication, you look forward through time, it really didn't show any significant changes there in lasting a fairly short period of time, 1 to 6 months. So that's encouraging, and that makes me feel better as a clinician to use the appropriate medications. Anxiety. I'm not going to talk about that. We're running out of time. So anxiety, everybody knows what that is. They're anxious. They worry a lot. They worry way too much. For generalized anxiety disorder, it's a problem. It's not just that you worry about appropriate things or you worry just a little bit. It really affects your life and it limits your function. And you have physical symptoms too. So treatment is initially the same, and you also have benzodiazepines that can be used in certain instances, in buspirone. And we already talked about this. I had to use the little laser at some point, just for fun. All right, SSRIs. As a class, you need to worry about sexual dysfunction, sleepiness, weight gain, and orthostatic hypotension. That's really critical in Parkinson's patients because that is a risk, especially in the Parkinsonian states because it's a higher risk for orthostasis, which means when you stand up, your blood pressure drops, you can pass out, hit the floor, hurt yourself. Or you can be really dizzy. And unfortunately, the medications that we use to help treat the symptoms of Parkinson's can make that worse, such as Cinemet, such as the dopamine agonist. They all can affect it. So you don't want to make things worse if you can, but we just have to monitor that. SSNI, so it uses both serotonin modulation and norepinephrine modulation, going back to the different neurotransmitters that we talked about earlier. So side effects of serotonin, and those are just a few, effects are symbolic. So serotonin, they're really serotonergic, which is good for anxiety as well as depression. Jitterness, restlessness, headaches. So those are there. From the noradrenergic, which is norepinephrine, sweatiness and dizziness. Tricyclics, you know, we don't use these much for depression and a Parkinsonian patient nowadays because of the side effects. These are great drugs. We use them in different ways. Still in today's society, or in today's medical practice, we use them a lot for headaches because they really work. And you don't have to build up to the dose to get all of the anticholinergic side effects that are listed there. These two they don't really fit in a good category. Called them lone wolves. I guess it was late and I was trying to think of something, but anyway. Wellbutrin is bupropion. That's activating medication. It increases both dopamine and serotonin. It's a very useful drug, often given at that 8-week mark if we are not as successful as we would like. Remeron, it's more sedating. So if people have trouble with insomnia, that's very useful, and it works both on serotonin and norepinephrine. So why mention the side effects? The side effect profile is really important on choosing the antidepressant because we don't have any really good studies that show, hey, we should use one of those antidepressants listed versus another. So you kind of have to match the side effect profile. All right. Nobody wants to withdraw from the medication. It's a little bit worse in some of them, but we just have to work around that. And if you wean it off, it's much less severe. Okay, so we're going to discuss each and every aspect of this slide. Are y'all ready? No. So I had it up here just in case I needed to talk about things and use up some more time, but we don't. We're over. So, all right, let's go. We're done. Thank you.